for the Searchlite 26 series webinar, which is on the induction of labor and initiated by Cancer Prevention and Relief Society in association with Bhimavaram, Navi Mumbai, North Odisha, Nashik, Noida, Panji, Palwal, Pandharpur, and Osmanabad Ops and Gynae Society. So first of my, it's my pleasure to introduce our convener, Dr. Sangeeta. Madam is a secretary of Bhimavaram Ops and Gynae Society, and she is a consultant as an Ops and laparoscopic surgeon at Seshadri Hospital. And Madam got a Shan Ratnam Young Gynecologist Award and Foxe Dhira Award. And Madam is also organized secretary of BUSA 2016 and 18. And Madam is conducting awareness program of Vikasan for the adolescent girl. So, Madam, over to you.
Thank you, Mr. Mehul, for that kind introduction. Moving forward, I would like to introduce Dr. Asha Jain, ma'am. She requires no introduction, but I'll just go through her CV. So right now, Madam is the director of SMSA Hospital Raipur. She is the medical director of CPRS. She's also been the elected member of CG Medical Council, zonal chair, Foxy Food Drug and Medical Surgical Committee, West Zone. She's the chairman, Mission Pink Health, IMA Raipur, executive member of ISCCP, Chhattisgarh, ISAR and Chhattisgarh SFM chapter. The previous post held by ma'am, she's been the president.
Enough, Sujya, make it really short.
Okay, previous post is president of Raipur OP-GYN Society. She's also been the vice president of IMA Chhattisgarh. And currently, ma'am is contesting for Food, Drug and Medical Surgical Committee chairperson. So requesting everyone to please support her. And I request ma'am to please take the program forward.
Thank you so much, Sujya, for that kind introduction. Before the formal welcome, I would like to invite everyone to invite the blessings of the divine. So we join hands in for a minute to pray to the divine. Thank you so much. Now, with prayers to the divine, I would like to invite all of you and welcome you to this 26th episode of Searchlight. This time, the searchlight is shining on induction of labor. ICOG was having a program and it was said that this is one topic that needs more attention. So today, our searchlight is on induction of labor. We have Dr. Pratibha Singh and Dr. Sadhna Gupta ma'am to actually take us through the entire subject, which we will revise in the panel. Our guests of honor are Dr. Mitra Saxena ma'am, Dr. Uma Devi K ma'am, and Dr. Kiran Kurkoti. They have all agreed to grace this occasion and spare their evening. So I welcome you to this webinar 26 Searchlight. I also welcome our chairpersons, Dr. Jyoti Bobe, Dr. Anup Kumar Ghose, and Dr. Manjusha Jindal, Dr. Sangeeta Wagh, Dr. Anjali Kulkarni, and Dr. Sudesh Doshi. I would like to welcome our expert, Dr. Sucheta Kinjvadekar, and panelists, Dr. Manisha Saxena, Dr. Lalita Swami, Dr. Kunika Chechi, Dr. Sachin Pawar, and Dr. Neeraj Kulkarni. Welcome, everyone. I hope this evening will add a little bit extra to your knowledge of induction of labor. Maybe it will help you to deal with patients a little bit better. Thank you and welcome. Now, I would like to introduce our guest of honor, Dr. Mitra ma'am. So ma'am is the chairperson, Practical Obstetrics Committee, FOXY, and this is a topic of practical obstetrics. So welcome ma'am. We are eager to hear a few words from you. She has a lot of publications, editor of FOXY Focus, Life-Saving Obstetric Surgeries, e-bulletin, convener FOXY GCPR on birth after cesarean section, member FOXY GCPR Ectopic 2020, and has chapters on stepwise devascularization, internal iliac ligation, PPH book, etc. She is a member of a lot of societies, has many awards, and
Dr. Asha,
welcome, ma'am. Over to
no,
you.
please.
Over
There's
to you.
nothing to welcome. We are all friends, and thank you actually for honoring me. And honest to goodness, I really feel that we all, the people who join the webinar, they need to be introduced. We are being repeated again and again. So humbly, I accept your invitation to be a part of your webinar. And I would just like to share my own thoughts. Friends, it gives me immense pleasure to be a part of a very, very beautifully crafted program. The idea, I mean, I liked the name Searchlight, and then to focus on one topic and then go threadbare about it. And I don't think it's a small increase in our knowledge, but I would say all the cobwebs would be evident and then they will be cleared up. Because, the speakers, they really take a lot of care in giving us the best, latest guidelines along with experience. And then when you have a panel, you have two brilliant speakers. There's Dr. From AIMS. Which place, Asha, please?
Dr. AIMS Jodhpur.
AIMS Jodhpur. So I'm sure that all our wonderful teachers just give me a moment to, Dr. Pratibha Singh, welcome. And I'm sure you're going to, make it and to the point. And then of course I know Dr. Sadhna Gupta for so many years, shedding latest information on the methods, and then a panel discussion on a case-based way. So I don't think there is any other better way to have a scientific program. Sorry, actually I must not be visible right now because I was just trying to little bit sorry. Yeah. So here I am back to your platform. So what I personally feel is that induction of labor, when it is done within the precincts of correct indications and the correct things which are there. For example, we should have a very good idea about the Bishop score, the indication for which we are doing. You do it right and you do it for the right reason. There's no reason why you'll be, you'll have a failed induction. But of course, sometimes it is imperative to induce labor and things are not favorable. So then how to deal with those cases? I just believe in one thing, that in obstetrics, जो आप करना चाहते हैं वो भगवान भी आपकी करा देता है. Of course, we have to not encourage inappropriate indications for induction, which means to say that if it is not indicated, don't just give in because of your convenience or patient's convenience. Whenever we take a shortcut, definitely in the long run, we are going to, make some, suffer because of that. Either it is uncalled for cesarean or it is a, later in the life, जो मेहनत करते हो मरीज आपको उसके लिए पूरा रिगार्ड देता है. So Dr. Asha, I must congratulate you. All our best wishes. Whatever we do, I feel that these academic exercises are very beneficial. And I will leave the mic for my other guests of honor. And I do hope that I'll be able to stay for as long as I can. Otherwise, I'm sure you'll make the recording available. Right. So best of luck to you for your future endeavors and all of us, that today, whatever time we spend, we go back more, alert and more well informed. Thank you so much. Thank you.
Thank you so much. Thank you for being there and in getting time out of, I know you have another webinar, but thank you for being here with me. May I have, yeah. So now I would, after Mitra ma'am, I would like to welcome Uma Devi ma'am. She is the secretary of Bangalore Society, but more than that, she is a very much loved teacher, WHO fellow of gynec oncology. She has many awards. She is professor and HOD gynae at Santosh Hospital, Bengaluru from 2016 till now, visiting professor at Ramaiah Medical College from 2012 and continues, and external member board of studies, Ramaiah University 2022. So she is, her special training in urogynecology, ultrasonography, obstetric and fetal Doppler, fellowship in daycare endoscopy, and fellowship in infertility as well. She has many, many contributions, and she's a really gem of a person to know. So welcome, ma'am. We would love to have your blessings to this webinar. You're muted. Ma'am, you're muted.
Very good evening to all of you. And I wish to thank Dr. Asha Jain for inviting me to this wonderful webinar, the Searchlight webinar. And this Searchlight webinar, your topics are so good, all practical day-to-day subjects where we have still some gray zones. And Searchlight is a wonderful name. Not only you're searching for the light, afterwards you make everything light also. So that easy for us to follow it in our day-to-day practice. And the topics and how you have divided the topics under various headings are really going to be useful for us. As you know, that induction of labor, many of us follow different methods. We have doubt whether we should follow the Western and induce at 41 weeks, or follow the Arrive trial and induce at 39 weeks, or think that for Asians are more prone for stillbirth after 39 and induce all Asian babies or women at 39 weeks. So it's a wonderful, very useful topic. And thank you, Dr. Asha, for the Searchlight series. I wish you success not only in your Searchlight programs, but also in your endeavor to be the chairperson of the Food, Drugs and Surgical Equipment Committee. Wish you all the best. And I'm sure that the speakers would be giving a lot of information for us, Dr. Pratibha Singh, Dr. Sadhna Gupta, whom I know very well, and she's a wonderful teacher and a wonderful academician. So also Dr. Pratibha Singh, and the co-chair guests of honor, Dr. Mitra Saxena. I've heard a lot about her, and Dr. Kiran as well. So the panelists also are very well accomplished, and I wish I stay for the whole discussion today. I wish success not only in this, but in your entire pursuit of spreading knowledge, Dr. Asha.
Thank you so much, ma'am. I'm blessed to hear your words. And if you can stay till the end, nothing like it. We would all welcome expert comments anytime. Thank you, ma'am. Now I would like to introduce Dr. Kiran Kurkoti, sir. Again, very kindly, he consented to be a guest at this webinar. He is the president of AMOGS 2024 to 26. He was the chairperson of MTP Committee Foxy in 2009, chairperson MTP Committee AMOGS, chairperson Medical Foundation Research and Training, joint secretary AMOGS, committee member.
Asha ji, that's all. Asha ji, thank you.
Thank you, sir. Thank you so
Thank
much.
you so much.
Thank you for being here. Always,
Yeah.
sir will pick up the phone at one call. So thank you, sir. Welcome. Welcome
Thank you.
to the webinar.
Thank you. Thank you. Well, it's a pleasure for me to be the guest of honor for the Searchlight 26th episode, and the episode is Searchlight 26, Induction of the Labor, but the spotlight is Asha Jain, because this is as Dr. Mitra rightly said, that you are taking so many programs and so many niche programs, and you are going into the nitty-gritty of the day-to-day obstetrics and enlightening us on the various aspects of obstetrics. So thank you so much for that. Actually, induction of labor, and traditionally we have been taught that obstetrics is all about masterly inactivity. So masterly inactivity and induction of labor are dichotomy and opposite words. So let us see in what all situations induction of labor is to be done, in what all it is not to be done, what are the complications, and to enlighten us on all these.
So you got muted by mistake. Kiran sir?
Yeah. We have got eminent faculty to enlighten us on this. Dr. Pratibha Singh, a very eminent speaker from AIIMS Jodhpur. We have our close associate, Dr. Sadhna Gupta. And of course, you'll be moderating on the discussion of case of induction of labor with my close friend and associate, Dr. Sucheta, who will be expert on this. And I would like to thank you on record to take all the AMOG societies with you for this Core Connect webinar. And I wish you a very best of luck in your endeavors in Foxy. Thank you so much for inviting me, and I look forward to be with you till 7 o'clock.
Thank you, sir. Thank you so much for those words. And now I hand over to Sujeshri to introduce our chairpersons and take the program forward.
Yeah. Moving to the next session, which is induction of labor, why, when, and for whom. Our speaker for this talk is Dr. Pratibha Singh. Firstly, I would like to introduce the chairpersons for this session. We have Dr. Jyoti Bobe with us. Madam is the president of Navi Mumbai OB-GYN Society. She is a consultant at Anuja Nursing Home. She's also consultant at Apollo Hospital and Kokilaben Dhirubhai Ambani Hospital. So welcome to today's session, ma'am. Moving on, the next chairperson is Dr. Anupam Kumar Ghose. Sir is currently the president of North Orissa OB-GYN Society. He's a very senior consultant with 41 years of experience in this field. His special interests are infertility, high-risk pregnancy, laparoscopy, vaginal surgery. He has been the organizing chairperson of Yuva Foxy in the year 2015. Welcome, sir. We have Dr. Manjusha Jindal with us. Madam has received special awards. She has been the Fimer Fellow. She has also been the president of Panaji OB-GYN Society. She has been involved in Menstrual Hygiene Outreach Society. She has numerous publications to her credit. She has contributed to chapters in books on medical education and obstetrics. She has also presented in various conferences and seminars, and her special interest is medical education oncology. Ma'am, welcome to today's session. I would request one of the chairpersons to please introduce the speaker, Dr. Pratibha Singh.
Good evening, everyone, and thank you so much for inviting me for this webinar. Dr. Pratibha Singh is professor and head of the Department of Obstetrics and Gynecology, AIIMS Jodhpur. She is founder secretary of Association of Gynecologists and Obstetrics. She is member of various societies and has more than 130 publications in international and national journals. Madam will speak about induction of labor, why, when, and for whom. I will take this opportunity to congratulate Dr. Asha Jain for organizing such a beautiful program, and I wish all the best luck for Madam in upcoming election. Thank you so much.
Thank you, ma'am.
Over to you, Dr. Pratibha.
First, let me thank Dr. Asha for inviting me in this webinar. It's indeed a fortunate even to be among all these stars. I'm seeing such galaxy of stars over here, and being one part of it, it's really an honor. Can I share my screen now?
Yes,
sure, ma'am, please.
I hope all of you are able to see my screen.
Yes,
I'm making it full screen.
Yes, ma'am.
Okay. So Dr. Asha had specifically asked me to a topic which to be said in a very simple language so that it becomes useful for all the common obstetrician and taking all the practical aspects into the consideration. So I'll be talking about the induction of labor, why, when, and for whom. Though this is something which probably all of us are doing regularly, and we all feel that probably we are very well versed with it. But when I was preparing for this lecture, I even went going through these guidelines, going through these different guidelines which we have nowadays. I got so confused that I thought that probably it's very difficult for any gynecologist to follow one guideline, and then one definitely gets confused as what to be done. So my disclosure is nothing much to say except that few of the images or few of the slides I might have taken from the Google. So what actually is induction of labor? It is the initiation of labor pains with the aim of achieving a healthy delivery of a healthy baby and a healthy mother. It is usually indicated where we think that probably continuation of pregnancy may compromise the well-being of either the mother or the baby. So it becomes an intervention, and as like any other intervention, it definitely has some complication, and one must be aware about it. WHO says that induction of labor is only recommended when there are very clear indications that continuing with a pregnancy poses greater risk to the mother or baby, or than the risk of inducing labor. So we have to weigh and balance which methods to be used, when to be used, and how to be used. So first of all, why? As it has been very clearly mentioned that continuation of pregnancy is likely to compromise the well-being of either the mother or the baby. So obviously it may have some maternal reason and some fetal clear-cut reasons. But besides these, what we see in our day-to-day practice, and many gynecologists are practicing it, there can be some social reasons. And then some concerns, some convenience, some prejudice of either the patient or the doctor, and then also it is done. So it has to be judiciously used for clear defined reasons. The general consideration which needs to be taken care of whenever we are planning for induction of labor is that there has to be a very specific medical or obstetric reason. It cannot be done for without any indication. We have to weigh the expected benefits of shortening of duration of pregnancy as compared to the harms which may occur because of continuation of harm due to induction of labor. So we have to see that there is no contraindications for vaginal delivery, and the indication and process of induction should be very clearly discussed and documented with the patient. The profile of the patient, the medical and surgical condition which she is having, the status of the membranes, whether they are ruptured or not, are there any scar on the uterus, what is the condition of the cervix, what are the methods we are going to use, what are the local resources available to us at our hospital, be it drugs, be it devices, be it the doctor, be it the nursing person. We all have to take into consideration whenever we are deciding about the induction of labor. And it is very important that an informed and written consent must be taken before this labor. Now, whenever we are planning the induction of labor, it is recommended that all the women should be admitted for induction of labor. So whenever a woman is being admitted, obviously there will be a lot of health resources which will be being used. It will require because this procedure has to be done under supervision. So there will be lots of requirement for manpower, and the bed and the resources will be used for the patients also. Maternal and fetal monitoring has to be continued, has to be started and continued throughout the induction process. Now, WHO has come up with one document recently, that is outpatient induction of labor. That is, induction of labor, can it be done as an outpatient procedure? It has been said that in selected group of women, it can be used only for cervical priming. That means a woman who's not having a good cervical score. And in those women, outpatient induction of labor can be done. For all practical purposes, me at our hospital, we are not doing an outpatient induction of labor, and I'm very skeptical about it, that how many of us are actually sending the patient home after deciding the induction of labor. So induction of labor as for today has to be done after admitting the patient in the healthcare facility. In fact, our own FOXY Good Clinical Practice Guideline GCPR also recommends that we should admit all these women once we have decided for inducing these labor. We all are very much aware about this Bishop score, and you will be hearing about it again also. But this is a very important score which tells us that what method we may be using, and it helps in discussing with the woman that what method would be best suited for her, what are the side effects of that particular method, and what needs to be further done in case one method fails. So whenever we are starting induction of labor, one must remember we have to have an informed consent. Many people recommend that we should have a pre-induction non-stress test. An intensive maternal and fetal monitoring will be required, and regular assessment maybe every 4 to 6 hours or early, depending on the method we are using, needs to be done. We need to shift women to the labor ward once she reaches the active labor, and we need to have the if at all she develops any adverse events in the form of either a hyperstimulation or anything, we should have an adverse event protocol that what needs to be done immediately if any time she lands up into problem. So the first thing, when should it be done? That means what are the indications for doing an induction of labor? The list is very long. I have included only those ones which probably in our day-to-day practice we are most frequently encountering. The first one is prolonged pregnancy. That means a pregnancy which has gone beyond 40 weeks. That means expected date of delivery. Rupture of membranes. That means she is presented with leaking either at term gestation or at preterm gestation. Hypertensive disorders of pregnancy, then gestational diabetes and over diabetes, a baby which is not growing well, that is the fetal growth restriction, an Rh negative, multiple pregnancy, intrahepatic cholestasis of pregnancy, fetal demise, malpresentation, previous cesarean, and the list is long. Though the list is very long, I'll be discussing only the important ones today so that we save the time for further discussion. And this is something which will help us in further deciding what newer options are available and what newer recommendations are coming up in our different guidelines. So the first and foremost, as Madam has already mentioned about the ARRIVE trial, where they have done the elective induction of labor at 39 weeks of pregnancy in low-risk women versus expectant management. And contrary to our belief, it was found that there was a lower risk of cesarean section, lower risk of fetal morbidity if induction of labor is done at 39 weeks as compared to expectant labor. Now, this is a very landmark trial which tells us that probably if we're inducing the women at 39 weeks, she has a better outcome, better maternal outcome, and better fetal outcome. But unfortunately, it is still not routinely accepted as standard of care because we know now that this ARRIVE trial has lots of fallacies in it, because the expectant group of women had a very varied group of women where the women may be even allowed to continue beyond 42 weeks of gestation. And we all know that as the gestation increases beyond 40 weeks, the likelihood of having a good outcome becomes a little compromised. So probably that might be one reason that still it is not routinely accepted. However, the standard care which is recommended at most of the places is that in a low risk women, the pregnancy can be safely continued till 40 plus 6 weeks or 41 weeks. However, whenever we decide to continue the pregnancy, it is equally important that we have a non-stress test. We must assess the Liker volume, and we reconfirm the gestational age once we have decided to go ahead with an expectant management. However, in a high-risk women, it's very important to individualize the management before planning for induction of labor. So it is important that we do induction of labor in an appropriate time. Induction of labor, many people do recommend that it may be done at 39 weeks, but after ARRIVE trial, probably people would be skeptical that whether we should really go ahead with this or not. Coming to another very important condition which we see, that is women presenting with leaking or rupture of membranes. It may occur at term gestation, that means pre-labor rupture of membranes, or it may occur in preterm, that means preterm pre-labor rupture of membranes. Now, the FOXY GCPR recommends that if a woman is more than 37 weeks, that means she is almost term, it recommends that induction of labor can be done. However, initial assessment with term PROM for confirmation of the diagnosis, gestational age, the presentation of the fetus, and the assessment of the maternal and fetal well-being is mandatory. Active management of term PROM with induction is associated with reduced maternal infective morbidity and increased maternal satisfaction without unduly increasing the cesarean section rate or operative vaginal delivery rate. So that is one very important advantage of inducing the labor at term, that is beyond 37 weeks. Very few infants will be admitted to NICU and very few infants will require postnatal antibiotics if we are inducing labor at 37 weeks. This is the recommendation by the FOXY GCPR 2018 guidelines. However, when we look at different guidelines, which all of us are very fond of looking at, that is ACOG, NICE guideline, the New Zealand Australian guideline, and SOGC, the Canadian guideline. Many people do recommend that, like SOGC recommend that immediate induction and delivery should be planned, while the ACOG recommends that immediate induction can be done. However, expectant management for 12 to 24 hours can also be done and can be offered. NICE recommend that offered expectant management up to 24 hours or immediate induction. So we have at a women who's coming at term 37 weeks and beyond, we have both the option. We can give the women the choice. We can explain all these risk factors, and we can decide accordingly whether she wants an immediate induction or she wants to wait for some time before starting ahead with the induction. Planned delivery within 24 hours results in less chorioamnionitis, less endometritis, few admission to NICU, and maternal satisfaction with no difference in neonatal infection rates and the mode of delivery. But once we talk about preterm pre-labor rupture of membranes, the situation might be a little different. It is said that approximately 3% of the pregnancy, they land up in PPROM, and 30% of the preterm birth are because of this particular condition. We will see that approximately 1/3 of these women, around 25 to 30% of these women, will have subchorionic, subclinical infection at the presentation. And it has been seen that almost 50% of them, they go into labor within 1 week and 75% within 2 weeks. So what needs to be done here? The FOXY GCPR recommends that if a preterm premature rupture of membranes have occurred after 34 weeks of pregnancy, the plan for induction of labor should be made after discussing with the women the risk of sepsis to the women and the baby, complications of preterm birth, and availability of neonatal intensive care units. If preterm pre-labor rupture of membranes have occurred at less than 34 weeks, but after the period of viability, induction of labor should not be carried out unless there are additional obstetric indication like already a compromised fetus or there is chorioamnionitis. Antenatal steroid and antibiotics should be administered in PPROM, and neuroprotection with magnesium sulfate should also be considered before 34 weeks and must be given before 32 weeks. Tocolysis is not recommended for these women. So after 34 weeks, induction, and before the 34 weeks, antenatal steroid, antibiotics, and conservative management is the preferred option. But again, once we look at the different guidelines, they also more or less say similar things. That these women should be offered, the RCOG says that these women should be offered expectant management till 37 weeks unless contraindicated, as it is associated with better outcome as compared to early birth. However, individualized discussion is important. The ACOG recommends that either expectant management or immediate delivery is a reasonable option if a woman is presenting after 34 weeks. Before 34 weeks, everyone recommends that a conservative management should be a better option. Now, coming to the next important condition, that is the hypertensive disorders of pregnancy. We know that these are a group of disorders which may have severe morbidity for the mother as well as for the baby. So women who are presenting with preeclampsia, it is said that induction should be planned at 37 weeks or maybe earlier if there is any evidence of maternal or the fetal compromise. For women who are presenting with only gestational hypertension, no other problem, pregnancy can be continued beyond 37 weeks, maybe even up to term if there are no additional problems. However, it has been seen that induction of labor is associated with improved maternal outcome and should be advised for women with mild hypertensive disorders beyond 37 weeks of gestation. In women with preeclampsia or gestational hypertension beyond 34 weeks of gestation, elective delivery can decrease the incidence of complication, severe hypertension, and need for the antihypertensive drug therapy. This is according to the FOXY GCPR guideline. So we all deal with these conditions, and for India, probably these are the best guidelines which recommend that we should be terminating as soon as we think that she has crossed 37 weeks, or if we think that there are significant risk to the mother in the form of severe preeclampsia or a compromised mother and the fetus. So it should better be terminated. We all know hypertensive disorders of pregnancy, they contribute to a major chunk of maternal morbidity as well as mortality. So I presume and I feel that the FOXY GCPR has done a very good justice in recommending that it should be beyond 37 weeks, it should be delivered. Coming to another important factor, that is the gestational diabetes and the induction of labor. We all know that gestational diabetes is gradually, slowly, and increasing all over India. We need to see, whenever we are talking about gestational diabetes and induction, we need to see what is the gestational age, whether the diabetes is controlled or uncontrolled. If it is controlled, whether it is controlled with diet, whether it is controlled with metformin, or whether it is controlled with insulin. Whether optimal glycemic control, even with these drugs, are achieved or not achieved, and what is the condition of the baby, how is the baby growing, and what is the estimated fetal weight. That means any sequelae of the gestational diabetes is there or not. So induction of labor is not recommended before 39 weeks in women with gestational diabetes, where the diabetes is well controlled only on diet. So if a diabetes is well controlled on diet, induction of labor should be deferred till 39 weeks. Induction of labor is recommended at 38 weeks of gestation if diabetes is controlled on insulin or oral hypoglycemics. That means we need to terminate those women who are being controlled on insulin and oral hypoglycemics. They need induction a little earlier. Similarly, at women who are on insulin and oral hypoglycemics, if the sugar is not controlled, they may require induction even earlier, between 37 to 38 weeks. So management of women with uncontrolled diabetes, it's important that it should be individualized and earlier induction is recommended. In women with gestational diabetes without any maternal or fetal condition compromise, no difference was detected in birth outcome if we induce them between 38 and 39 weeks, or we do an expectant management. So it all depends on whether the diabetes is controlled or uncontrolled, and whether it is being controlled with drugs, with insulin, or with oral hypoglycemic agents. When we talk about the timing of delivery, we have very good guidelines which are being given by the Ministry of Health and Family Welfare in 2018. And they say that TDM, if it is well controlled, it can be taken even up beyond 39 weeks. That means even up to 42 weeks. However, if it is controlled on medication, either insulin or the OHAs, it should be terminated between 38 to 39 weeks. And if it is not controlled that or inadequately controlled, it needs to be individualized. It needs to be discussed with the woman before recommending for induction. The ACOG recommends that same, more or less similar kind of recommendation we see in ACOG, except that ACOG recommends that we can go even beyond 40 weeks in a woman who is well controlled on diet only. Similarly, NICE also recommends that the women should be a women who is well controlled on diet can go beyond 40 weeks. But however, if a woman is not well controlled, early termination, early induction in between 37 to 38 plus 6 weeks is recommended. Now coming to another fetal condition, that is the fetal growth restriction. Whenever the fetal growth is not adequate, it's important to terminate the pregnancy timely to prevent stillbirth. The timing, however, is guided by how severe is the fetal growth restriction. Are there any deterioration in Doppler parameters during intensive fetal monitoring and associated maternal factors? So a fetus who is just having normal Doppler but overall small birth weight probably can be very well taken up to 38 weeks. But if a fetus is having Doppler changes in the form of either uterine artery PI is increased, or the middle cerebral artery or DV is showing changes, or there is absent end diastolic flow, obviously all these group of women will require individualized approach, taking into consideration what will be the outcome of the baby if we deliver them early. Similarly, we have to also take into account what NICU facilities are available to us before recommending induction in these group of women. Coming to multiple pregnancy, specifically the twin pregnancy. If it is an uncomplicated twin pregnancy, there are no contraindications to vaginal delivery, then we can induce labor at 37 weeks. 37 weeks because twin pregnancy, they generally achieve maturity much earlier. So 37 weeks induction can be recommended. However, there is contraindication of induction. If there is contraindication of induction of labor in twin pregnancy, if it is a monoamniotic twin, or the first twin is a non-cephalic presentation. In fact, both of these are indications for elective cesarean sections. Early birth at 37 weeks of gestation compared with ongoing expectant management for women with an uncomplicated dichorionic twin pregnancy does not appear to be associated with increased risk of harm. So we can very well safely advise them termination of pregnancy. Similarly, if we look at different guidelines, the ACOG recommends that if it is an uncomplicated multiple gestation, that means diamniotic dichorionic, we can advise them induction between 38 to 38 plus 6 weeks. However, if it is monochorionic diamniotic, induction can be advised between 34 to 37 plus 6 weeks. NICE recommends that timing of birth should be discussed and elective delivery after 36 weeks can be advised. However, they also do recommend that antenatal steroids to be given for these women if we are planning to deliver them before 36 weeks. It is appropriate to aim for vaginal birth for a monochorionic diamniotic twins unless clinical indication for cesarean section is there. So we can see there is clear difference in the gestational age where the standard recommendation for induction is there. So in our setup, it's very important that we follow the FOXY GCPR guidelines because they are practically made for our country, and they're very good in that term because it is taking care of our group of women, our scenario, and are made for us actually. Coming to another important aspect, that is the intrahepatic cholestasis of pregnancy. Earlier, it was said that induction should be considered between 37 to 38 weeks to improve perinatal outcome. An earlier induction, maybe 36 weeks, may be warranted if there are severe biochemical abnormalities, especially severe derangement in bile acid level. This is the FOXY GCPR recommendation, but we find that the other guidelines just significantly differ with the FOXY GCPR guidelines. It is said that if the bile acids are more than 100 millimole per delivery, delivery can be offered at 36 weeks or 37 weeks. Delivery between 34 to 36 weeks is only offered if the total bile acids are more than 100, along with if there is one of the following conditions are met. That is, there is excruciating and unremitting maternal pruritus, which is not relieved by drugs. There is history of stillbirth before 36 weeks due to IHCP with recurring intrahepatic cholestasis of pregnancy in this time. There is pre-existing or acute hepatic disease with clinical or laboratory evidence of worsening hepatic function. This is recommended by Society of Maternal Fetal Society of Maternal Fetal Medicine, and it is endorsed by ACOG in 2021. So it's very important that women who's having a serum bile acids less than 100, anywhere between 20 to 100, it needs to be individualized and careful judicious decision to be taken, taking consideration of the women's choices as well. Now, coming to the intrauterine fetal demise. Intrauterine fetal demise is, as it is a uh, very hard situation for the women and her partner. So they should be given proper support and they should be counseled for how to cope up with this problem. Women should be offered a choice of either immediate induction of labor or expectant management. We all have heard this story कि अगर हम छोड़ देंगे तो probably जहर फैल जाएगा. Nothing such thing generally happens so early. In the presence of sepsis, preeclampsia, abruption, immediate delivery may be planned. Otherwise, if we do not find any risk factor for the mother, it, the choice for immediate induction versus expectant management can be given to the parents. However, we have seen that most of the women, they desire prompt delivery. In more than 90% of the patient, we have seen if we leave the women, approximately 90% of them, they will go spontaneously in labor within 3 weeks. The real risk is the DIC, that is disseminated intravascular coagulation, but it has been seen that it is reported in less than 25% of the women and only in those women where the dead fetus has been retained for more than 4 weeks. So we can very safely wait for 1 week, 2 weeks, 3 weeks without any problems. However, one needs to be careful that DIC, a test for coagulation profile needs to be done twice a week so that we are very sure that she has not gone into DIC. And for induction of labor, the choice which will be dealt, what choices to be taken, I'm sure my next speaker would be Dr. Sadhna would be talking about this. So I'll not go into the details of it. Now, coming to previous cesarean section, many of us are really very, very scared of this particular condition because of the risk of chances of uterine rupture. We all know it is increased whenever we are inducing labor, though the absolute number is still very low. But we are so scared of this uterine rupture that induction in previous cesarean is something which not many of us are very fond of doing it. It's important that whenever we have decided for the induction of labor in a case of previous cesarean section, we must see what is the condition of the cervix and how many cesarean section has been done. What was the condition of the scar if we have the whether it was a lower segment cesarean section scar, whether it was a classical scar or extension has occurred or T-shaped incision has occurred. So all these conditions, obviously, we will not go for induction of labor. These are the conditions where we straight away go for elective cesarean section. But rest all conditions where we think that vaginal delivery is possible, we can safely induce these women at term. And it has been seen that if the women are adequately induced, majority, almost 60% of them, they will have a vaginal delivery in spite of previous section. And this is high, this conditions becomes higher if the cervix is favorable after a vaginal delivery. So previous cesarean section, again, a judicious induction of labor should be advised to the women. There are lots of contraindications also for induction of
Pratibha
labor.
ma'am, thoda fast.
Yeah, ma'am, but just 2 slides remaining. There are lots of contraindications for the induction of labor which needs to be considered. That is the placenta previa, umbilical cord presentation, abnormal presentation, and so many other conditions. So whenever we are talking about induction of labor, the contraindication of for induction also needs to be taken care of. And the complication of induction of labor, one must remember specifically the uterine hyperstimulation, uterine rupture, and the failed induction. And whenever we are counseling these women, it's important that we must tell these women what are the indication, what are the problems which may occur with the methods used for induction of labor. So whenever we are doing induction of labor, the outcomes must be measured and audited frequently in wherever we are. That is whether vaginal delivery was achieved within 24 hours or not. What was the cesarean section rate in induction of labor? What is the uterine hyperstimulation rate, uterine rupture rate, and what happened to the severe maternal morbidity and morbidity? Same thing for the fetal condition, the APGAR score at 5 minutes, NICU admission, neonatal encephalopathy, severe neonatal morbidity, and disability in the childhood and the perinatal period are one of the problems which needs to be monitored and audited frequently. And maternal request for induction of labor is non-medical reason and should, as far as possible, should be avoided except in very rare exceptional circumstances. So to conclude, I would say, whenever we have decided for the induction of labor, we must once again reassess the gestational age prior to induction of labor, counsel the women regarding the benefits and risk of induction of labor. There should be clear indication of the induction of labor, clear documentation of the induction of labor along with the consent of the women. Individualized management for induction of labor is recommended, and all these women who are undergoing induction of labor, they will require frequent, intensive, continuous monitoring for maternal and fetal well-being. This will going to increase the workload to the hospital and cost to the women. I think with this end my talk here. Thank you so much.
Thank you so much, Dr. Pratibha. Manisha ma'am, over to you for your expert comments. Manjusha
Request the chairpersons to please add their concluding remarks.
And thanks, Dr. Pratibha, for a detailed discussion on why and when. You have nicely recapitulated all the guidelines and help us recollect all the information we had. At this junction, I also thank Dr. Asha Jain for inviting me to be associated with this webinar and giving insights into induction of labor once again. And also I wish her all the best for her foxy tenure. Thank you.
Thank you, ma'am. Thank you so much. Dr. Pratibha, it was as I had expected. It was really, really very good. I told you, you are a fantastic speaker and everybody has evidenced it today. So thank you. Yeah. Thank you so much.
Thank you, ma'am. Thank you.
And
may I add something?
Yeah.
Yes, sir.
Please go ahead, sir.
Yeah, thank you, Dr. Pratibha, for that illustrative lecture. But I had a few question marks in induction of labor. You gave a full list of indications for induction of labor, but I really wonder if anyone in the private setup who doesn't have an institute-like thing would go for induction of labor for twins with first cephalic. Most of the twins now are delivered by cesarean section. No one ever would think of, though theoretically it is possible, but with small setups and with so much amount of controversy and medical legal sword hanging on you, I think anyone would not like to go for induction of labor in twins. Secondly, again, same to the thing for trial of labor after cesarean section. People don't even think of trial, put aside induction of labor for trial of labor after cesarean section. And about waiting for induction of labor after intrauterine fetal death, though we know that we can safely wait for 3 weeks, but the amount of mental stress that relatives and the patient would go, no one would wait for 3 weeks, though even it is known that they will deliver vaginally. They want an immediate delivery. Thank you so much for your listening. Thank you, Dr. Pratibha. Thank you.
Sir, thank you, sir. Thank you for your comments. I'm sure that most of these things which I have talked about might have sounded a little theoretical to many of you. Yes, we are routinely, being in a medical college and being teaching to the students, we are routinely using induction of labor for previous section, for twins as well. So obviously, I don't want this. The message should go from this platform that induction of labor cannot be done for twins or induction of labor cannot be done for previous cesarean. Obviously, it is very important that one should be aware about what facilities they have at their particular place, what infrastructure they have, what are the NICU facilities, what are the neonatal facilities available, and then only decide for the induction of labor. It's very important that.
Thank you so much.
Yeah.
Thank you. Physician yeah, requesting everyone to please mute. Yeah.
So, Jay, if you would please take the program forward.
Yes, ma'am. So, moving on to the next session, which is methods of induction of labor. The speaker for this session is Dr. Sadhna Gupta, ma'am, who requires no introduction. Firstly, I'll introduce the chairpersons. We have Dr. Sangeeta Wagh, who is the president of Nasik OB-GYN Society. She's also director and consultant of Usha Hospital Maternity Home at Bujpal Farm Road, Nasik. Welcome, ma'am. The next chairperson is Dr. Anjali Kulkarni, who is the director of OB-GYN Women's Health. She's the secretary of Nasik OB-GYN Society. Welcome, ma'am. We have Dr. Sudesh Doshi with us. Sir is a senior obstetrician and medical legal consultant who's been working at a rural setup in Agra Hospital, Pandarpur. I hope I got it right, sir. He has experience of delivering over 15,000 babies at his setup. He's the chairperson of Adolescent Health Committee and also Medical Legal Committee. And he has been the president of Pandarpur OB-GYN Society and also the zonal coordinator for AMOX. Welcome to today's session, sir. I would like you to please introduce the speaker, Dr. Sadhna Gupta.
Yeah, it's a great honor to introduce to the house great teacher like Dr. Sadhna Gupta. She actually needs no introduction. She's teacher of teachers. She has been professional bodies affiliation to so many things like SAFOG and with various sports like Foxy. She has to her credit many individual awards and honors for the community work. She has more than lots of publications and awards. So starting from Foxy, Dr. DC
Please make
Datta
it full
Award.
screen. Mehul, please make it full screen.
She has been a key person in organizing so many conferences like Foxy ICOG Adolescent Conference in 2022 over last so many years to annual conference at in 23 and 24 of the national conference. Orations, she has been awarded at Dr. Jan Thapa Oration and all other orations. It is a great honor for me to introduce Dr. Sadhna Gupta to the house. Dr. Sadhna, ma'am, please.
Thank you, Dr. Sudesh, for a very loving introduction. And first of all, thank Asha for this invite. And my regards to all dignitaries, Dr. Mitra, Dr. Uma Devi, and Dr. and all the president and secretaries of all the societies. So, and all the coordinators. So, organizing such level of program involving so many societies is a great task, and I heartily congratulate Dr. Asha Jain, who is taking this this all very good academic program and doing a great effort, and all the help for the coordinator is very, very important, and I really congratulate Dr. Sujeshi, who is the coordinator of the program. So induction of labor is something which is actually put a lot of question, and I bring greeting from land of Buddha, Gorakshnath, and Ayodhya as well. And the important thing in the subject of the induction of labor is that we can never obtain peace in the outer world until we make peace with ourselves. So this is something which is very true at every moment. So it is the classical I am Donald, and the classic teaching remains the same. My voice is audible.
Yes, ma'am. You're audible, ma'am.
So the ancient view, why we have to induce the labor? Because the world is very harsh and the fetus want to come out. So this is something we talk philosophically, but the important thing is with the brilliant lecture by Dr. Pratibha that we should only induce when we are sure that we can do better. So this is something which we always have to remember. And before going to induction, into the subject of method, we will say we must know that what is induction of labor. When we want to we have the aim to achieve vaginal delivery within 24 to 40 hours. And successful induction, when we succeed in that, and elective indication, induction is when there is no actually induction, but we do for many social reasons. And we must know what is tachysystole and hypertonus for all the junior people, that because we are going to face these complications. Incidence is on the rise. In developing world, it is less. In Africa, it is least, that is 9.6%, and it is globally rising. And what the ARRIVE trial, which have shown that it can be equal, but actually the ground realities are quite different, and we must be very aware of it. So because there is a lot of risk for induction of labor. Firstly, we are not able to achieve our aim, that is vaginal delivery. Then we can have all the complication and the consequence of the induction of labor, especially the postpartum hemorrhage. So we have to take this decision very, very carefully. This is a wonderful paper by Dr. Nusrat Aziz. Actually, it is a chapter. And beautifully described that how the adverse neonatal outcome is associated with use of oxytocin in labor. And it is more important considering the fact in developing world, in India and the South Asia, the half of the stillbirth are due to the intrapartum care. So this is something we have to consider despite any arrive trial which has been done always done in a research setting, that what are our all situations and what are our key priorities. So predictor of success of labor, again, like a classic word of iron donut, it is the classic Bishop score. It is the human touch. It is the human observation, what we look. And it is the same classic thing. How is dilatation? How is effacement? What is station? It is soft heart and what is the position? So it is the touch which can have a lot of interpersonal variation, which as we grow in experience, as we grow in age, we are more accurate in judging the simple thing and the predictability of the success of the induction of labor. So mechanical method, I will start from the simpler method because it is the physics. Physics is something which is, so many of us have been fascinated. It is a rule, it is a truth. Light has got this velocity, sound has got this velocity, triangle has got 180 degrees. So it never fails. And the mechanical method, despite their simplicity and a very aggressive pharmacological method which we have, it stays with us. So first of all is the membrane sweep. All obstetricians are using it. Patient comes close to term, you just do a sweep and you expect that the woman will be coming in the next morning or the next evening. How it works, it depends on the release of endogenous prostaglandin. So we are not giving any exogenous prostaglandin. We are stimulating the body to produce prostaglandin. Virtue remains the same. It is very simple, no cost, no lag. It is a complete competitive. There is no risk. And we maintain integrity of membrane as well. So the labor follow a more natural pattern of onset. The studies also shows that the efficacy of the membrane sweep is quite good without any increase in infection rate. Only simple thing also have to be learned, and we have to look for the contraindication, whether there have been the rupture of membrane, any active infection, any placental abnormalities on ultrasound, and any vaginal bleeding of unknown etiology. So this method has been enjoyed by both medical profession as well as the lay public, and it stimulates the spontaneous onset of labor, decrease postpartum delivery, and need for subsequent medical intervention. Second is the Foley's catheter. People right from the very beginning, right when the humans started having their birth, the many things have been tried. So it has been proposed right in 1700 that the Foley's catheter, and what it is a mechanical thing, that is the application of pressure on internal and external os, and it is again the pressure vectors in addition to the inflammation and prostaglandin release, which play role in the cervical ripening process. There has been the simple thing, Foley's catheter, how to put, but the few things which we have to always keep in mind, use speculum. We cannot go do through the digital examination. Where the cervix cleaning is desirable, catheter is inserted. It is about the 2 balloon catheter, which for Indian OB/GYN as well as the abroad, it is not that available. But if you had, then you have to inflate the upper balloon close to internal os with 40 ml saline, the second balloon with the 20 ml of the saline. And when the speculum is removed, then each balloon is filled with the 20 ml slowly till both balloon contain 80 ml of saline. So this is something which has been it is approved for the induction of labor. Foley's catheter simple is not approved. It is a off-label use, but due to less cost, easy availability, it is usually it is a primary choice by the obstetrician. Evidence for Foley's catheter is very, very favorable. PROMET trial shows that it induces cervical ripening without inducing uterine contraction, effective, safe, acceptable, and a good meta-analysis shows in the good number of patients that the combined use of the Foley's catheter and oxytocin significantly reduces induction delivery time as well as it increases the incidence of vaginal delivery. So this is important that we always, before going to any pharmacological method, we choose the simple thing which can be easily done. Laminaria tent and dial-up-in now not we are getting. Once upon a time it was a routine, especially for the termination of pregnancy like IUFD. But still they are available in many countries. Now coming to pharmacological method, which is now the main armamentarium for the modern obstetrics, but we have to remember that arms are always double-edged. So knowledge is a advocate, is a sword. It allows you to do. You always set for you are confused in various guidelines and you are sometimes not able to take decision what you have to do the patient which is sitting before you. So the prostaglandin, which has been released by membrane sweep or by the Foley's catheter inflammation, we are giving from the outside. So we have the PGE1 that is misoprostol and PGE2 that is dinoprostol. So these are the two agents which we are having, and PG act through all paracrine, autocrine hormone, and a lot of receptor. So the simple thing, we know prostaglandin, but the nature complexity is very difficult to understand, and they work at many levels. But for all practical purpose, what we are interested in, how to optimize these pharmacological drugs for the best of the use for the patient. So PGE2 is available in 3 forms, that is gel, time-release vaginal insert, and 20 milligram suppository. So these are indication for the cervical ripening. So if Bishop score is low, these are our primary choice that we use for the cervical priming. Cerviprime dinoprostone gel, we have used, I think, around 25 years, and it is a good choice. It may be repeated after 6 hours for maximum 3 doses if required. And women, after applying, you have to have the speculum, you have to have all aseptic precaution. Women should be kept in bed, like on the table for 30 minutes following application, and then monitored closely for the uterine activity and the fetal heart rate. So this is the Cerviprime which have been using. Now Cervidil and the Propes, we have now available in our country as well. Initially, it was only from the Propes, which was not very widely available. So this is something very add-on to our armamentarium. It is 10 milligram dinoprostone vaginal suppository. It is a flat rectangular vapor which has got an insert. So it releases slowly around 0.3 milligram per hour prostaglandin, and it is used as a single dose, which is placed transversely into the posterior vaginal fornix, following which the patient remains recumbent for at least 2 hours. A study shows that it has got the very good efficacy. There are a few very good studies from our own Indian Institute that vagina is soaked with the normal saline, it works even better. The important thing, because it is available and many of us must be using or will use in the very near future, it has to be removed either after 12 hours or when the active contraction start, or at least when there is like a not that strong, the good uterine contraction 30 minutes before start of oxytocin. Side effects are few. So Cerviprime is good. Cervidil is also very good because this is easy to apply and you don't have to put the speculum. So this is very important. Many people know when we use Cerviprime, people are not, the patient sometimes is not comfortable. So this is an add-on thing and it is a slow release. And the beauty of Cervidil is, or this vaginal insert is that when you have any hyperstimulation or tachysystole, you can immediately remove it, which revert to the normalization of uterine contraction and the fetal heart tracing if it is non-reassuring. So this is something very important, but we have to be very careful that Cerviprime or the dinoprostol gel also to be kept into the fridge, and this Cervidil has to be kept into the freezer. So this is important because when we have some interactions, so say when it was a pilot project or using, the resident are keeping Cervidil in the pocket of their apron, and surely it is not going to be effective, and it is a wastage of a very, very potential good and the drug for the induction of labor. So this is important. And what is the manufacturer guideline? That oxytocin induction should be followed for at least 6 to 12 hours. So not before 12 hours before you insert the Cervidil. So this is important and the evidence is quite favorable. This is a 40 trial worldwide which shows that it is a very effective drug for the induction of labor, especially when the woman has got the low Bishop score. There can be nausea, vomiting, diarrhea, and the temperature rise, which happens with the prostaglandin. Now, misoprostol, which has become darling of OB/GYN and has got a very turbulent journey in the pharmacological industry. It just came out of experience because misoprostol was the drug which was developed to prevent the gastric ulcer, and the letter to editor always, actually, our all organization, our society, our country, we need rebel who work and who think and who have the courage to speak. And the world is changed by only those people. It is not the only following. You have to experiment, you have to work, and you have to speak loud about your success as well as failure. So it was a simple letter to editor by Margulis, who says that it is a very good drug for the termination of pregnancy, and initial studies was on the IUFD patient. Since then, a lot of publication, RCT, meta-analysis have shown, and our experience, that the misoprostol is a very good drug. It is remained off-label by their manufacturer, but GOI as well as the good professional organization recommend this drug for the induction of labor. The few beauties of this drug is it is very cheap. Refrigeration is not needed. Very, very important issue when our country this year is having the 50, 52 degree temperature all around the country. It can be given oral, vaginal, rectal, sublingual. Every route is okay. But for the purpose of induction, we must know that which route we are choosing, because oral administration gives the peak action in 12 to 60 minutes and falling rapidly by 120. That is 2 hours. But the vaginal administration is like a slow release suppository, and the peak action is between 60 to 120 minutes and decline gradually at 240 minutes. And it is rectal, what we giving for the PPH prevention, it is around 2 hours. So this is important when we are choosing the route of the drug. We know at what time period patient need very, very close monitoring. Now about the dosage, we have a lot of academic discussion, panel, and the program. So it is not about the only route. It is 25 people are giving 50, 100, 200, and I will say few very clear message, what you should dose, you should do, so that you are saved of the medical legal issue, and as well as it gives safety and having no less complication with the misoprostol use. So it is 25 microgram vaginally every 4 hours, which is found superior. Like around cervical ripening, what is the cerviprime or the cervidil. Buccal and sublingual use might be as effective, but it can cause the more tachysystole as well as the more complication. You can have tachysystole, meconium passage, because it affects on the fetal gut. It is not due to fetal distress because it is affecting fetal gut. And in this scarred uterus, it is a very dangerous drug. And actually, before the people say, the drug people say that it is, I use this thing long ago, and the patient within 1 hour got this rupture of uterus. That was the no child alive second cesarean section and the IUFD. So this is important that all professional bodies says for all practical purpose, it is contraindicated in women with previous cesarean section. So 25, 50, 100, 200, 400. So I will give only one message, maximum 25 to 50 microgram every 2 to 4 hours or every 4 to 6 hours. So this is, going beyond that might increase your complication and might increase your problem. So higher doses, more tachysystole, and more meconium stented liquid. You can have fever, chill, and diarrhea. And when the patient is having especially prom or something, you have to be careful that you have given misoprostol. Fever is due to chorioamnitis or it is due to the a potential drawback of administered PGE1 is that, what is the thing? With the misoprostol, why it is so strong? It starts cervical ripening and the uterine contraction at the same time. So when we give the like a PGE1 followed by oxytocin, it is one step. It is cervical ripening followed by uterine contraction. But the misoprostol act the both things simultaneously. So it is a strong one. So it is liked by obstetrician, maybe sometimes patient, but we can have more complication. Misoprostol can be drunk also. So the one message to audience, they can try that. 25 micro, sometimes difficult to get. So you dissolve one tablet into the 200 ml of water and sip 2 or 3 drops every 2 hours. So this is few studies which shows, and it is paper from our own, that he says that the PGE1 is a better choice. Now, oxytocin is our old friend. It is a love hormone. The nature, the God has given us, and love can be both ways. It gives you pleasure and it gives you a lot of pain as well. So it has onset of action in 3 to 5 minute, half-life of 1 to 6 minutes. Important thing is that the women respond to oxytocin very differently. Why? It is because of the concentration of oxytocin receptor expression and the receptivity of the receptor to the exogenous oxytocin. We have to be very careful that oxytocin need around 30 to 40 minutes to get the steady level. So no change of the dosage should be done before 30 minutes. So this is something oxytocin we have to understand pretty well, and we have used since like all what we say, all memory. So this is important. More close to term, a better Bishop score, you are going to have a better result from the oxytocin induction. For all practical purpose, low dosage regime is as effective and more safe, and you can give 5 units in 500 ml, and you can give low dosage and you can give the high dosage. You start right from the very beginning, it is 3 to 6 mu, or you start from the 1 to 2 mu per minute and gradually increase only after 30 minutes till good uterine contraction are achieved. And for my purpose, when the patient is having good uterine contraction, sometimes you can consider that you withdraw the oxytocin and allow the patient, the labor to go on its own. So it is low dose, high dose infusion pump for many settings. Dr. Sudesh has rightly said, we have a lot of issue with the small scale private sector, which are giving very good obstetric service to our people. So in low dosage, you have more safety as well as you have a almost equal efficacy. Love can be dangerous. It is always, and it is important that when you have the oxytocin, especially overdose and something, you can have uterine tachysystole, and by the love deceives you also, it can be deceptive. So this is a very important observation that the obstetrician caregiver tend to increase the dose because it is not effective. So you are giving 20 to 40 ml, then you have the 40 drop to 60 drop. So this is important. And the second thing is that oxytocin has the unpredictable therapeutical index. So some women can be oversensitive to oxytocin, and that's why the Institute of Safe Medical Practice in 2008 says that the oxytocin is the list of high alert medication that bear heightened risk of harm when used in error. So we have to be put these things in our all hard disk. Oxytocin can be risk of PPH, a modality for the treating PPH. It itself can cause the postpartum hemorrhage, and it is the study proven, and it is the something very important observation. The less common risks are anaphylactic reaction, PPH, of course, cardiac arrhythmia, fetal epiplogynia, pelvic hematoma. When you are giving with the 5% dextrose and for the prolonged period, it can cause water intoxication and hyponatremia. And the antidiuretic effect is also, and one very concerned about it, that if you put the woman on the long, high dose of oxytocin, the child can have a possibility of autism. So it is not a study, but it is something question mark. So misoprostol, oxytocin. So oxytocin is cheaper. It also needs refrigeration. I have worked like 2013. We have worked 2 or 3 years as a chairperson Safe Motherhood Committee that oxytocin to be kept in fridge. Mind it, before 2012, the oxytocin was kept right in the shelf, and we have really worked very, very hard for 3 years for this path oxytocin project, and with all effort. IV, and it is oxytocin is less effective, and there is a low Bishop score, more remote from the term, and we can have all the issue. And the prostaglandin is costly. They need refrigeration, not PGE2, but it is good effective drug when we have the report from the term. This is oxytocin care bundle. So this is something I will say we should always consider. It should not be used alone in IOL with the poor Bishop score. Always better to give as an infusion. We have to have a close or continuous CTG and never change the drug before 30 minutes. Mifepristone is something, a new block. Till now, I have not used for the live full-term fetus, but we have a very good studies which shows that the mifepristone is not only for the termination of pregnancy, like in IUFD or anomalous baby, even in a full-term pregnancy, we can use mifepristone as a good priming agent, even as the OPD purpose. The 200 milligram oral dose seems effective, and we have good paper from our own Indian population that mifepristone is an effective agent as a cervical ripening agent and adjuvant to non-pharmacological or pharmacological. So many people can try that mifepristone. It is a paper from Kanan Yalikar who says that it is a very effective thing, and it is Sandhya Kumari, Journal Sapog. Again, it is shown all the paper that the mifepristone can be a good adjuvant as a cervical priming agent. And of course, in IUFD and anomalous baby, mifepristone, before going misoprostol, it is a very good cervical agent. Anodonor has been tried, isosorbide glyceride tried it, but the results are not good. They are disappointing. Artificial low rupture of membrane, when you can, like the cervix is dilated, you have done the cervical priming. This is the thing which we do, amniotomy, and immediate effect is if preeclampsia, lowering of blood pressure, if polyhydramnios, maternal distress, control of bleeding in APH, and it arrests the progress of abruptio. So in abruptio, it is something which we practice, and assure still there is no contraindication like active HERS, mesoprevia, HIV, or the cord presentation or possibility of cord presentation, and you can do with all aseptic precaution with amniotic or sometime by Cocker's forces. So the again advantage of the simple thing, high success rate, you can observe amniotic fluid. This is very important. You do the amniotomy, you find thick meconium, and suddenly everything changed and you go for the quick cesarean section. Limitation can never be done for unfavorable cervix. So you have to have the cervical priming agent before, and hazard that it is a no retreat from decision to delivery, chance of umbilical cord prolapse, amnionitis, accidental injury to placental cervix or fetal part, and sometimes suddenly amniotic fluid embolism, like it is very, very sudden, and every person, be it a nurse or resident, must know that it is not a that simple procedure. So two are better than one. So IV oxytocin with amniotropy is a very, very high chance that the patient had delivery within 24 hours. So the combination are better. Like our country also says that the collaboration is better, cooperation is better. No single drug is very useful. We need helping hand for everyone. Miss Monitoring, Dr. Pratibha has already said, but just we have to say what drug you are using. Be very careful when this drug is effective. So misoprostol and the PG to 30 minutes to 2 hours, and oxytocin for the 30 minutes when it is doing. So this is very important. And now this is very important. That is the tocolytic therapy. You have done induction of labor and suddenly you find non-reassuring CTG, you are having Turkey systole, and what to do. So Cervidil is very good drug about this. Oxytocin is very good drug because you can withdraw immediately. You cannot do it with misoprostol or the Cerviprime. But as a principle, the tocolytic should be available. Our all staff must be knowing that this is in the box, close to our CTG machine, and the terbutaline, and when terbutaline is not available, the nitroglycerin. These are the two things which should be available whenever any patient is undergoing induction of labor, because again, I emphasize that in around 1/3 of the situation, the induction of labor or use of oxytocin has been found the detrimental cause for the neonatal adverse outcome. Do the nature has its role? Yes, the nature is always there. So nipple stimulation, sex for intercourse. Castor oil, when we started our residency for around 6 to 7 years, it was a norm, but still I will say it is now condemned. But there are few very good new studies which shows that it can be a reasonable choice. So these are the simple thing. Herbal supplement, in our country, it is, I will say, homeopathy drug. Many homeopathy in our city, you take this tablet and you will be good, and sometimes they really work. Acupuncture. So a lot of complementary things are being studied, but of course for this, there is no like a funding or something, so we don't have the good data. we must have a policy when we label that it is a failed induction of labor. So this is very important. We have to make our institutional protocol that now this we consider as a unsuccessful induction and go for the alternative thing. So success have many fathers, failure has none, but it is a failure actually which make a person experienced and is strong. So important thing is when you have failed, first of all, give good time. It is not so you give 1 or 2 hour oxytocin induction or a 1 cervical priming agent and don't allow the patient wait for the 12 to 24 hours after cervidil or after cerviprime. But if it is a failed, again review indication, what is urgency of delivery. Again, you have to review maternal wishes into account and say what is happening. GOI is very, we are so fond of RCOG, SOGC, and we are the like 74-year independent country. And why we are looking for other countries which might not seem practical, distant from our people. GOI guidelines are wonderful. I will say the oxytocin, how beautifully they have written, which could be understood by anyone. So it has given indication. It is not recommended in normal pregnancy, GDM, and suspected fetal macrosomia. GOI also says 25 microgram 2 hourly or 95 microgram vaginally 6 hourly, and oxytocin 2.5 in unit. What actually our obstetrician we are not using usually 5 unit and 10 drop, which is increased by 10 drop every 30 minutes. So you go to GI guideline, you see you have low dose, high dose chart in that book, and you will not able to understand how drop or how many drop when to increase. But GOI guidelines are so simple that it can be understood by everyone, very simple language. And if hyperstimulation occur, it shows terbutaline and the salbutamol also as a tachyphytolytic drug. So beyond guideline, ask right question to yourself, introspect and awareness. This is keep us going. So this is a Lancet study published which shows that it is an Indian study. We have Indian author and we have the foreign people also. It shows in 34% of women in Indian, around 17 hospitals, there was no indication for augmentation of labor. So this is the care bundle with which I am going to end my presentation. Is ask right question. Is there a need for induction of labor? Is fetal condition good to tolerate induction? Is there uterine scar? What is the method of induction plan? Do we have the CTG? Do we have the tocolytic? Have we defined what is the timing, what we consider failed induction of labor? And is there a minimum recommended time duration suggested for starting oxytocin? So this is important. And again, I will finish with the golden word and the classic word that let's one reason for inducing labor be carefully and honestly weighed, that the circumstances be favorable, and let the Rubicon be crossed with no lingering glances behind. So it is life, it is love. You don't have to look back once you have decided. Key message, induce only for indication, individualize, make roadmap for the journey. Don't promise anything. Backup plan for surprises and gems, reach safely, because you are dealing with the most difficult journey, and journeys are humbling and learning. Thank you very much. Thank you very much for the opportunity.
Over to the chairpersons.
Thank you so much, Dr. Sadhna Gupta ma'am, for such a very detailed and a very informative lecture. So many take-home messages, and those will be very useful for all of us. Thank you, Dr. Asha Jain ma'am, for conducting such wonderful webinars, and wishing you all the very best. Thank you so much for inviting me as a chairperson. I do appreciate it.
Thank you so much. Thank you. Sudesh sir, would you like to add something?
Yeah, as I said, it's a very good lecture, comprehensive, completing almost all the aspects of induction of labor, from nipple stimulation, natural methods, from other ancillary methods like homeopathy and acupressure and all. And we know, though methods keep on changing, drugs keep on coming, the age-old method of sweeping the fingers, sweeping the membranes. And I would like to add an anecdote that we had a PG teacher who used to say that if the cervix is dilated, then only you will be able to sweep the fingers, but your fingers have to be long. He used to say that only the male member should sweep the membrane so that he gets the finger inside the cervix and sweeps it very nicely. The female residents should have smaller fingers. It would be difficult for them to go into the cervix and put the finger and sweep. So he used to say that there was no actually discrepation or comparison in between male and female students, but he used to insist that the male member of the unit should do the sweeping of the membrane so that it is done very rightly. Thank you so much. Thank you, ma'am, for the lecture.
साधना मैम, डॉक्टर कुनिका ने एक सवाल पूछा है. डॉक्टर कुनिका, you can ask it yourself.
Good evening, ma'am. Thank you. Ma'am, it was nice presentation. I just want to know what is the high dose of oxytocin which can lead to autism?
Actually, this is not like a very well proven study, but it has given us a very cautious thing that that oxytocin must be playing a role at the different level. So one thing is that oxytocin is being considered for the treatment of the autistic children as well. That is the another issue. But autism is oxytocin, because it has been used, has been propagated. So we will say that the low dosage schedule are better than the high dose. We can say up to now this thing, because the studies are not that well founded, but it has got like a alarm bell for us that whenever we are using any drug for induction, we must be considering that we use the minimum effective dose, be it a misoprostol. It is not, some people are very like 100, 200, it's okay, अरे कुछ नहीं होता, 6 hours में dilatation हो जाता है, but the message is that it is 25 to 50 micrograms. So for every drug we have to say. So I don't have an answer, we have just put a right question so that it is in our mind that the drug high dosage and the prolonged use of oxytocin can be dangerous.
Means जो हम 2.5 और 5 का use करें, that is okay ना?
Yes, that is okay. That is okay.
Okay, ma'am. Thank you.
Thank you so much. Sadhna ma'am and Dr. Pratibha, Uma ma'am and my chairpersons, if you will please join for the panel, which is basically just going to be a practical demonstration of the theory that you have already taught us. So I would be really grateful. So I'm going to start the panel now. Thank you, Sadhna ma'am. That was really great.
Thank you, Asha, and all the best.
Thank you, ma'am. Sudesh sir, आपके लायक भी question है, यदि if you have a little bit of time to spare. So,
sorry.
These are my experts. I have Dr. Sucheta Kinjvadekar and 5 panelists. So Dr. Sucheta ma'am is was president of Navi Mumbai Society 2017 to 19, organizing secretary AMOX 2014, organizing chair West Zone Yuva Foxy 2017. She is champion and assessor of Lakshya Manyata. Our panelists are Dr. Manisha Saxena, who is secretary of Noida Society, works at Prima Care Super Specialty Hospital and Motherland Hospital, and she has many positions in Noida Society. She teaches MRC Urji courses. We have Dr. Lalita Swami ma'am, who is a consultant at Swami Hospital. She is the president of Osmanabad Society. Dr. Kunika Chechi ma'am, who is the president of Palwal Obstetric Gynec Society. She is a gynecologist and IVF specialist. Ex-senior resident at MAMC, has many publications in national and international journals. We have Dr. Sachin Pawar, who is the secretary of Pandharpur Society, and he has a best paper presentation in AMOX 13. He has a case study published in Jogi on mannitol in PIH and eclampsia. Welcome, Dr. Sachin. We have Dr. Neeraj Kulkarni, who is the dynamic treasurer of Panji Society. He did his post-graduation from Vellore. He is a fellow of Minimally Invasive Laparoscopy and Infertility Society, and he is an active member of Panji Society, Foxy, and International Society for Study on Prevention of Perinatal and Infant Death. His secretary, Dr. Afzal Siddiqui, had all good words to say about him, that he's very, very dynamic.
My
So
God.
I
Thanks, ma'am.
welcome all my panelists. And Dr. Lalita is caught up in an emergency. And right now, I have not been able to contact Dr. Manisha. If she's here, I welcome you. But requesting everyone to just take the questions as they come. This is the latest paper, which is still under publishing. So this is where I've taken these details. So I would just like to ask, I did not allow Pratibha to actually speak on it. So anyone can tell me what are the contraindications of induction of labor? We've discussed all the indications. Now let's talk about the contraindications.
Yes, I would like to add, ma'am.
Yes, sir. Dr. Sachin?
Yes, ma'am.
Yes, sir. Tell me.
In cases of diagnosed case of chorioamnionitis, previous multiple uterine scars, previous hysterotomies, as well as cases of placenta previa, in case of severe antepartum hemorrhages. Yes.
So
and
here in this list, it is
presentation.
That vasa previa is also a contraindication. But how many of us are actually doing a scan in labor? How are we going to diagnose vasa previa?
Not diagnosed.
See, if we don't diagnose, we are going to have a stillbirth. So we are going to have take home from this. It's not just a repetition. So how are we going to diagnose vasa previa?
Ma'am, may I? This is Neeraj here. Ma'am, in our experience here, what we have seen that vasa previa, in our experience in the past 2 years, we had 2 cases of vasa previa. One was with twin pregnancy and one was with a singleton. So at the time of, in the twins, especially when we wanted to, we had induced her labor. And at the time of rupture of membranes, basically we felt like there is something running across the membranes, which was which we felt before rupture, that it's like a cord-like structure. So what I presumed that it is a cord prolapse which is going to happen. So I posted her presuming it is a cord presentation. But when I did the section with my this colleague, we found out that it was vasa previa, ma'am. And this is how we were able to save. But on ultrasound for the one singleton pregnancy, what we found that the while we are doing, the cord was inserted in the, it was a low-lying placenta, and the cord was inserted at the edge of the marginal, the edge of the placenta. And there the vascularity around the cervix was very high, ma'am. I think that is the only way when we should have a very strong suspicion and a doubt that, okay, that is maybe a vasa previa. So I think it is going to be mainly a situation where when we have a suspicion, then only we can think of vasa previa. Otherwise, it's very difficult to diagnose.
What I would like to say here from my experiences, that when we do a first trimester ultrasound, the placenta is invariably in the lower segment, right?
Yes.
But when you do a second trimester, it will have gone a little higher. And when you do it in the third trimester, it's gone much higher. But a placenta that was less than 2 centimeters in the second trimester at the TIFA scan, when it migrates up, usually that is when, and it's a sort of, the lower 1/3 is where the cord is inserted. That ends up as a vasa previa. Okay. So when you are doing a third trimester scan, you should actually look for vasa previa. You need to look for it. You need to see where the cord is inserted, and you need to see the Doppler where it's going. In the checklist, there is nothing to search for vasa previa. But when you are actually doing it, because once you have a healthy baby, we are the ones who get the sweets. But if something happens, we are
Sure.
the ones whose hospital gets broken into. So
Sure.
we have to have a look at the lower uterine segment. You can do a transvaginal scan, put in a Doppler and see whether your cervical area is clear. You rotate the probe 360 degrees and have a look. That is the best way to guard yourself if you're going to go for induction of labor.
Sure.
Can I add something?
Yes, please.
As you correctly said, vasopressia needs to be an antenatal diagnosis. Intrapartum diagnosis, it's one of the DD of APH.
Yes.
So whenever there is, everyone should look for cord insertion, and whenever there is marginal or filamentous insertion, then one needs to be see for vasopressia. So in TIFA scan, as you have correctly said, a sonologist needs to document cord insertion, whether it is in the center or marginal. If it is marginal, we need to keep that thing in mind. That's all. But then incidence of vasopressia is not that common. Okay.
That I agree,
So
ma'am.
in
But when
general,
it happens,
contraindications for induction are all contraindications for vaginal birth. Whenever these patients are for elective C-section and contraindicated vaginal birth, then I think all of them are in contraindications for induction.
so here in the contraindication, it's also active genital herpes and HIV with a viral load of more than 1,000 copies. This is something that we also need to keep in mind. Indications Pratibha has dealt with in great detail. So let us go to the situations. So each situation has something unique and we will address that and finish it fast. So this is a post-term pregnancy, 42 weeks. Are you going to induce it or not? Or are you going to take for a direct cesarean section? Dr. Sachin?
Ma'am, I would induce.
Yeah, yeah. Please, sir.
What are you going to look at before you actually induce? She's 42 weeks, but so what? What are you going to look at, make sure before you induce?
Dating.
Exactly.
And weight of the baby.
Dating, weight of the baby, and
bishops and other complicating factor with the mother, and ultrasound with Doppler according to the Doppler parameters.
Okay.
Amniotic fluid and the non-stress test NST.
That's it. So if it's post-term, it's gone beyond 40 weeks, and it is actually gone beyond 40 weeks when you have compared it with your ultrasound dating in the first trimester. Then when do you want to induce? You want to wait till 41 weeks? You want to do it at 42? Or you want to, whenever the patient comes to you after 40, you want to do it? How many of us are comfortable if the patient has gone beyond 40?
Ma'am, I am usually not doing after 40 weeks until and unless all other parameters are normal, and I feel after 1 week she may land up into normal delivery, the other things are favorable. Only then I will allow her to progress till 41. Otherwise, I will prefer induce at 40 weeks.
Okay. Sucheta ma'am? Sucheta ma'am?
Yeah, as Dr. Sadhna has projected the GOI guidelines, I do follow them. At 40 weeks, I do a scan. If Liker is normal, Doppler is normal, then I wait till 41 weeks. But after 3 days, patient comes again for an NST and, tell about fetal movements. Now, more than 50% of patients who cross 40 weeks, by 41 weeks, they go in spontaneous labor. And spontaneous labor, we all know, are much easier. If she is beyond 41 weeks, if she is ready to wait and come again for fetal surveillance every third day, in my practice, I do wait. But beyond 42 weeks, no. 42 weeks, if I am going to induce patient, I again confirm amount of liquor. I may do early amniotomy because chances of thick meconium are very high. So even if Bishop's is not favorable, I may do early amniotomy as a mode of induction. These babies, liquor is bound to be less, and possibility of cord compression and all that stuff is still there. So close monitoring is important. I avoid chemical agents for ripening of cervix in such patients.
Okay. So basically, you're saying that you want nature to take its course as much as possible with
So
a little
till
bit
41
of-
weeks, yes.
So, Sudesh sir, this is for you. How are you going to counsel the patient about risk and benefit of induction versus expectant management? It's already gone beyond 40 and the patient wants to know why you want to interfere. So how are you going to counsel
Well,
that?
at my place, I would not go beyond 41 weeks. Even at 40, I counsel them about the risks and benefits that if we go beyond 40 weeks, up till 41 weeks, there is rare but still a chance of sudden IUFD, about 1 in 1,000. It is documented in our textbooks post-exam. Beyond 41 weeks, 1 in 1,000 is the risk of sudden IUFD without any signs or symptoms. Yes, if the cervix is fine, then we have to tell them that induction will take a long time. Induction needs extra monitoring, and after induction, it is going to be a painful process. We have to ask the patient that it will take 24 hours, because whenever you say that you are going to induce the patient, the relatives think that you induce the patient like that, the patient will deliver within 6 hours. So for induction, it has to be made very crystal clear that the induction to delivery interval is going to be minimally 18 hours or maybe 24 hours or more than that. That is to be very clear, because what happens, they are ready for induction and you induce and within 6 hours they sit down and they said that now we don't want to wait, we want a cesarean section done. So you have to make them very clear, and you have to tell them that when the nature takes care of the patient, that when it is a natural induction onset of labor, then it is much more reason to deliver the patient rather than induction of labor. But we have to tell them about the pros and cons of the induction versus expectant management, telling both the risks and benefits of the both of things.
Thank you, sir. So, in your decision to induce labor, do the patient's preferences have any role?
Yes, definitely.
Sucheta ma'am?
Yes, of course. Our job is to tell pros and cons. Counseling is not just addressing. We need to give information, and it is patient's choice. Patient needs to keep watch on fetal movements. Now, when I say I wait for 41 weeks, I mean that there is no hypertension, there is no preeclampsia or PIH, there is no diabetes, either on diet or any other drug. And this is not even the borderline IUGR. If baby is at third centile right from beginning, though her Doppler is normal, I will not allow that pregnancy to go beyond 40, because these babies, small babies, can succumb even to the mild distress of labor.
Yeah, ma'am, actually for FGR, it is recommended if it is the third
13.
centile, not to cross 38 weeks.
Correct.
So
Correct.
now,
So when I say 40 weeks, I have excluded all these. I just wanted to make that clear.
So a post-term delivery in a multiparous versus a nulliparous, is there a difference? Neeraj sir?
Yes, ma'am. The basic difference, what we usually experience in our practice is that a multiparous a lady responds better to the stimulation agents what we use. Even if we go for directly amniotomy with oxytocin and even the stretching of membranes, she might come into spontaneous labor the next day. So what we follow here is that, ma'am, we don't admit them. We stretch and sweep them. We send them home, and with proper counseling, we call them back. In nulliparous, it is not the same. We start the response. What we have seen is that from the 38th or the 39th week, we may do her a pelvic examination to assess the pelvis. do a stretch and sweep if it is favorable, and call her back after a week. And by usually 40th week, usually the cervix is ready. I would want other people on the panel also to help me whether this approach is helping, ma'am, in your practice, because here we are finding that this twice after 37th week serial dilatation of the cervix has definitely helped us improve the vaginal delivery rate compared to the other methods. Your take, ma'am.
Sadhna ma'am, would you like to say something here? Sadhna ma'am? No.
I think what he has said is correct. Multi-paras patients, they respond to stimulating agents very quickly. To my experience, I have seen multi-paras not getting contractions with oxytocin or anything. Amniotomy really helps.
Yes,
because
yes,
that really engages head very
Head.
quickly. Then they open up very fast. So with even mild contractions, priming oxytocin in 2-3 centimeters, early amniotomy can be done in a multigravida patient. I may not do this in a primigravida patient.
Yes.
Yes, one thing which we must remember that as the parity goes on increasing, the size of the baby is going to a little more. So if it is a previous normal delivery with a little bigger baby, maybe 3.5 something like that. Now, if it is a multiparous patient and a little postdated, we have to look for the size of the baby. As we know that with the parity, with the gravidity, the size of the babies also goes on increasing.
True. So what are the potential complications of induction and post-term pregnancies? It's post-term. What are the potential complications?
I will take the question.
Oligohydramnios, hot
Yes.
compression, and fetal distress. Specifically for post-term pregnancy. Otherwise,
this is the
all other
post-term. This is
complications for
post-term. This case is post-term. So basically, and they land in cesarean anyways. What are the chances of perinatal complications in the fetus?
More
Yes.
chances of meconium aspiration,
Yes, and
fetal distress, and during delivery, more chances of shoulder dystocia. Nothing else.
Neeraj, would you like to add something, Dr. Neeraj?
Yes, ma'am. I'm not getting anything.
Perinatal, postnatal complications in the fetus. If that child has been induced at 42 weeks or 41 weeks, what are the chances of perinatal complications?
Unless there is meconium staining, I don't think so. There would be any complications as such. If there is no fetal distress in the during the process, if the and the baby has been monitored well and she had an uneventful birth without any fetal distress or without any shoulder dystocia, I don't think so. There is any specific complication pertaining to the this thing at because of the post term pregnancy, ma'am.
Sucheta ma'am, you're happy with that, or we add?
Yeah, I think because I do anticipate distress and such things intrapartum. But once baby comes out and cries wail, I don't know whether baby has any added risk of post-maturation.
Okay. So now we proceed to the second case. What are the triggers for delivery in preeclampsia? Because you need to know those triggers, then only you want to induce the pregnancy, right? So what are the triggers in preeclampsia where you want to induce the pregnancy?
Well, first thing I would like to say that apart from preeclampsia, any patient who is having preeclampsia should not be let to go beyond 37 weeks. She should be induced at 37 weeks. So the gestational age is the first trigger point. Secondly, severity of eclampsia, definitely it is going to affect your induction protocol and the timing of induction. If it is the severe preeclampsia, I would say BP not controlled with antihypertensive drugs, BP going beyond 150, 100, 160, 100. Patient shows signs of impending eclampsia like flying reflexes, severe headache, vomiting, or convulsion, eclampsia itself, then it warrants immediate induction of labor.
Okay. Kunika, Dr. Kunika, would you like to add something here?
Ma'am, associated with these features, if there are associated IUGR, oligohydramnios, and if BP is not controlled on more than 2 drugs, or if there is associated deranged liver functions, then I will like to induce the patient at 38 weeks or before if it is like that, uncontrolled.
Okay.
And if controlled, I
What
will
is the
carry
method you
for
want to use here? What is the method you want to use
for induction.
Yes.
Ma'am, for induction, I will just assess the patient, and according to the Bishop scores, I will decide. I usually prefer cervical rightening if the Bishop score is not good and patient is a primary gravida.
Which agent would you prefer?
Ma'am, I usually prefer dinoprostone gel and followed by oxytocin. That is my preferred choice. With misoprostol, usually there is sudden distress, and at our setup, it is a small setup. Sometimes anesthetist is not available. So I usually prefer Serviprime followed by oxytocin.
Okay. Anybody wants to differ? Want to say something else?
Yeah, if it is very bad cervix, then for ripening, I would like to use mechanical methods like maybe putting a Foley catheter for around 12 hours or 18 hours. And after the cervix is ripe, then go on for dinoprostone gel and amniotomy and oxytocin.
Okay.
Yeah, I just wanted to say something.
Yes, ma'am.
We all know, I mean, we have to induce this patient. Any other inductions, for example, at 40 weeks, 41 weeks, I may give 2 days, 3 days as well, you know, depending on the indication. But for severe preeclampsia, we need to target delivery within 24 hours. So if I do mechanical dilatation or Serviprime gel, after 12 hours, I'll start oxytocin. I'll do early amniotomy and see the progress of labor. But severe preeclampsia, and what is severe preeclampsia? Either that high BP or liver enzymes or low platelets or proteinuria or HELP or impending eclampsia. So anything of this severity, we should target delivery in 24 hours. Luckily, severe preeclampsia and even eclampsia patients progress very fast. But if she has eclampsia, after stabilizing, we should do early amniotomy and target delivery even in less than 24 hours. So maybe 12 to 18 hours, she will deliver.
Okay.
Ma'am, sorry to interrupt.
I just want to say one thing. I will prefer to decide or delay the decision of induction, but once I will decide, I will deliver the patient in 24 hours, not more than that. Meaning by once I start the induction, I will not decline it later on.
Yeah, that is fair.
So
Yes,
decision
Dr.
is
Sachin,
first.
you wanted to say something? Dr. Sachin, you wanted to say something?
Ma'am, I wanted to ask one thing. Ma'am,
Yes,
in our
Neeraj.
now current clinical practice, unless how I would look at it, unless I am working in a proper institutional setup with a proper ICU backup, then only I would even think of inducing a patient with severe preeclampsia. This is how I would look at the situation, because severe preeclampsia, I think, is always associated with having either IUGR, oligohydral, multi-organ dysfunction. So for me, practically, induction of labor in a small setup is a no. Because assessing the favorable, for me, the outcome is more important. Ultimately, the mother and the child should walk out. Another aspect what we have noticed is that even a blood pressure of 140/90 on 2 recordings, nowadays we are initiating on labetalol tablets. So which is helping us, according to the new trials, even the the eclampsia, the incidence is come down. this is what I have experienced. If I'm wrong, please correct us, the other panelists, senior doctors. In your experience, ma'am and sir, are you seeing that there are eclampsia patients visiting your emergency department with very high 180, 110 BP, 200, 220 BP? Is that the scenario which we are still seeing? I doubt.
No, sir. No, sir. Now, after improvement of antenatal care, eclampsias are
Yes.
not easily visible.
Yes, ma'am.
I see this difference from Delhi to Rohtak. So it is more in Rohtak, but very rare in Delhi. So as
Yeah.
there is advancement of antenatal care,
There
definitely
you
there is reduced risk of eclampsia. Impending is
let
there.
us proceed
IBP
to
is
the
there,
next question.
but not
Okay.
That
eclampsia.
how are you going to manage the blood pressure? You are going to give labetalol, right?
Yes, ma'am.
Yes.
For induction, are you going to give Maxel?
Ma'am, if
Yes.
impending eclampsia, yes. If controlled BP, no.
No, but you are inducing this patient, right? Now
Yes,
she
ma'am.
has
Eclampsia, if I am inducing, I will start magnesium sulfate for her.
Yeah.
exactly. So
No,
this
ma'am.
is
I'm
one
not
take
giving.
home that you need to start Maxil along with labetalol. So
In all patients, ma'am?
when you are inducing for severe PIH,
Okay.
when you are inducing for now, if you don't induce, you've given Maxel, her blood pressure has come down. Are you going to continue the pregnancy or you still want to deliver her?
Deliver,
will
ma'am.
deliver.
No,
Deliver,
ma'am,
ma'am.
deliver.
Agree.
Deliver.
So you're going to deliver her. So,
But magnesium sulfate we give for seizure prophylaxis. It's not for control of blood pressure.
yes, ma'am.
And there is no harm in continuing pregnancy after discontinuation of Maxel. As we give this Maxel even in threatened preterm, less than 32 weeks, it acts
Ma'am, I'm not
as
talking
a
of Maxel. I'm
neuroprotection.
saying you have a patient of severe PIH, which with your medication has been controlled now. So do you want her to continue the pregnancy or you want to terminate it?
No.
No, ma'am,
Once you
we'll
have
terminate.
decided to induce severe preeclampsia, bringing down blood pressure is just stabilizing her. It doesn't mean that
So
she
this
should
has to
continue.
be the take-home point for everyone that if there is acute PIH, then just terminate the pregnancy. Controlling the blood pressure does not mean controlling PIH.
Correct.
No, as we all know that as we have been taught in textbooks and our good old teachers have told, treatment of PIH is termination of pregnancy.
Yes.
Single word.
So now there is FGR. If somebody would tell me in very short, how would you define FGR? Just the definition.
Less than third percentile of weight.
Yes.
And along with or without Doppler changes.
So less than third is definitely IUGR. And
Yes.
if there are the other criteria is if AC or EFW is less than the 10th centile.
Yeah.
Plus Doppler changes.
Plus Doppler changes.
Doppler
Or
changes.
even if it is more than centile, but it has jumped down by 2 quartiles. So
Yes.
more than 50, it has come down. It was 80 and it has come to 30. It is still FGR. So these fetuses are compromised. So if it is early FGR, then what is your plan going to be? Are you going to induce or you're going to do a cesarean? Early FGR means 28, less than 28 weeks. Severe early FGR.
So severe early FGR, you mean less than 28 weeks maturity.
Yes.
And then indications for delivery at that time is reversal of end diastolic flow at umbilical vessel. Viability and prognosis for such baby is very guarded. So I need to counsel patient thoroughly at this periviable gestation. If her baby weight is 400 and 500 grams and I am delivering the baby, chances of intact survival, neonatal and complications in early life, patient should be very clear about. Now, if they still want to try on baby, say for example, this is an IVF pregnancy
the
or a
baby
very
is
precious.
700 grams. The baby is 700 grams.
700 grams survival is possible, but they should be aware that it is not 100%. Still, there are chances of early mortality, morbidity, and so on. So, we need to give clear picture to family, and if they decide to save this, still try on this baby, then there is no role of induction, but direct C-section.
This is exactly what I wanted to bring out, that in severe early FGR, you are not going to do induction. Now, if it is late FGR, you have noticed it at the 36-week scan that this baby has now got FGR. There are Doppler changes. There is increased flow in the middle cerebral artery, reduced flow in the umbilical artery. Are you going to try for induction or are you going to do a cesarean?
If there are Doppler changes, the CPR ratio is 1 or somewhere like that, C-section is going to be the answer. Trying for an induction, you are going to jeopardize the patient because the baby will not be able to sustain the stress of labor, and already is FGR, may land up in more complications. At that time, if it's FGR with Doppler changes, I would like to go for section, no induction.
Dr.
If it is,
Yes, ma'am. I will agree with sir. If there are Doppler changes with reversal and MCA changes, I will definitely go for C-section, ma'am.
Dr. Kunika?
Yes, ma'am, cesarean.
Dr. Sachin? You're muted, sir. Dr. Sachin, you're muted.
I'll go for cesarean if there are Doppler changes like absent or reverse diastolic flow. We will not induce the patient and jeopardize the baby's health. Yes.
Now we come to you, Sucheta ma'am. You are our expert. Now let us know.
Yeah, this topic is very close to my heart.
Yeah.
If it is a FGR baby and the diagnosis is beyond 33, 34 weeks, or for that matter, 32 weeks, then there are certain set protocols. If it is stage 1 FGR, we have to induce by 37 weeks. And what we mean by stage 1 FGR means low CPR. Okay. So we can safely induce this pregnancy and there is no need to do C-section. If there is absent or reversal of end diastolic flow, then yes, no role of induction. It has to be C-section. If it is in between, like low CPR is because of raised umbilical artery resistance, then I may probably go for C-section. But stage 1 and 2, we can safely induce patient. There are other factors to be considered, like other comorbidity, if there is preeclampsia or diabetes, and amount of liquor is another very, very important thing. In FMF and Barcelona FGR calculators, we actually get a good recommendation whether we need to consider delivery or C-section, something like that.
Ma'am,
So
we've done
management is
early and late
stage-based.
FGR. Yes. Management is stage-based. Stage 1, you can go for induction of labor. Of course, you have to look for the offsetting indications, the cervix and this and that.
Yeah.
Now, one question, there is a baby of FGR. Now, it has certain perinatal problems, right? Now, are they because of the induction or they are because of FGR? And how are you going to talk to the patient about it?
They are mostly because of the low growth retardation. Most of the complications are due to that.
Yeah, so that has to be part of the counseling before you induce, because if there is any problem, and it has to be a written counseling, right? Otherwise, everything, if you do something, you know, patients will also say they gave an injection to stop the pain.
That's the most common allegation.
Yeah. So we
are yet to find a good tocolytic or a drug to arrest the labor. We are still looking for it, that what can stop the arrest the labor. We are not able to find it.
But the patients will say that they gave an injection and the pain was stopped and they then did a cesarean section.
Yeah.
So similarly, something happens to the baby, our counseling has to be very clear that it is FGR with its complications and not the induction per se. Now, this is PROM, this Sadhna Didi had taken in great detail. So, in practice, how do you diagnose PROM? The patient says, I have leaked, my bed was wet. She comes to you, you see nothing. So now how are you actually diagnosing in your practice, PROM?
Ma'am, if on per speculum examination there is no leaking, I will confirm by ultrasound. If Liker is adequate, then I will wait and watch.
Okay.
For diagnosing PRM, I will take into factor history also. We have to clearly ask her whether it was a leak, maybe a bowl full of water or something like that, or it was just spot by spot. You have to do a per vaginal examination, per speculum. You look for vaginal discharges if they are there. And on the speculum, we can ask the patient to cough and look for direct trickle from the os. Most times you can get it if it is a frank leak. But if you're not able to see a leak, and if the patient gives a positive history of having leak of soaking her petticoat or maybe some amount of water on the floor, then you have to believe her. The supporting evidence definitely will be ultrasound.
Means you've done an ultrasound. I'm asking you, how many of you do that fibronectin thing? Is it available?
No, ma'am.
No.
Simple
What
thing if you
about
want to do,
the
we
litmus
have done the
paper
residency
test?
days, is you can do a fern pattern test on the microscope. You can get help of your pathologist, and it really works. A simple drop of Liker dries up and you get a ferning pattern. That can be done, but no one does it. But it is simple and can be done.
What
Easily
about
available.
the litmus paper test?
No experience.
No, ma'am.
Not
Not
doing.
doing it. No.
Okay. So
Do you do, madam?
means I've heard it discussed so many times that I'm asking, we don't really do it. Patient says that I have leaked, she shows her clothes, you do an ultrasound, and you believe it, sort of. You don't look for corroborating evidence that way.
History,
Suppose
if asked
patient has
clearly and
leaked
given instructions,
and she has
yes.
leaked completely, and that's why now she is dry, then even clinically you can feel that it's all baby and no Liker. But if we have ultrasound in our OPD, I think that's the easiest way to say that you have not leaked at all.
Yeah.
If she has leaked, then I think, and if you see it with your eyes, that means she has leaked.
So now if
And
she has
after
had
with
a
history,
PROM,
just one point I would demand. After history, she says that she has leaked, and ultrasound, you get a good amount of Liker. You can give her a pad, or make her wait for 4 to 6 hours and see that if it soaks or not.
Demonstrate.
Demonstrate.
So now supposing she has a small leak, would you want to continue that pregnancy? How long? And would you give an antibiotic cover? These are practical things that we do in our OPD.
What do you mean by small leak?
Means there is a very little Liker that you can see. You can see there is that fern pattern, as sir is saying. That pad is getting 1/3 wet in 6 hours. And inside the AFI would be something around 7 or 8.
Ma'am, if it is a term pregnancy and this thing, induce and deliver.
Yeah. If it is 34 weeks,
then
we can give expected.
Conservatively managed, I would do a CRP, high sensitive CRP, see the values. If it is beyond 20, ma'am, I would definitely consider counseling them regarding the high risk of having neonatal sepsis, cover her with antibiotics and consider delivery. If the CRP is normal, I would keep her on a antibiotic course for 5 days and repeat CRP once a week to see that the baby reaches the viability period.
Sucheta,
And if it is less than 34 weeks, I would like to give her steroid cover up also for the lung maturity.
Yes, yes, sir.
If she is 34 weeks, if she has completed 34 weeks and we are sure that she is 34 weeks and there is probable leaking, usually the labor starts within 24 to 48 hours.
Yeah.
Till then, I will do scan. I'll do just the baseline total and differential count, WBC count, and not CRP at first go. Do a vaginal swab and send it for culture, and I'll send patient home with tablet erythromycin. That's all on the presumptive diagnosis of PPR or PPROM. Now, after 2 days, 48 hours later, she comes again. If all those pads are dry, I will reassess and see if Liker is still that 7, 8 it has increased or it has reduced. Now, if liquor has reduced, I'll consider this as evidence of, liquor, continuous drainage of liquor. And since she has completed 34 weeks, I think I should induce this patient.
Because Sadhna just said now 1/3 will have chorioamnionitis associated. So everybody agrees that we would give her an antibiotic cover, right?
Yes.
And depending on the gestational age and the status of liquor, either continue or terminate.
Correct.
Yeah.
Right? So
now, when patient goes home, we need to say that she has to avoid intercourse and there shouldn't be a tub bath or any vaginal wash or something, because any of these will enhance chance of infection.
To ask her to look for fever also.
Correct.
If she feels febrile, she has to come back.
Now, Anna, this is a case where there is a maternal disease, whether it is hypertension or diabetes. If it is uncontrolled, when are you going to induce? And if it is controlled, when are you going to induce? When do you want to terminate this pregnancy? Maximum.
34 weeks, ma'am.
34 weeks is not exactly right.
Uncontrolled diabetes, 34 to 35 weeks, maybe the time to intervene, terminate.
Dr. Neeraj?
No, ma'am. Uncontrolled diabetes, whatever it is, if the fetus is healthy with a good amount of amniotic fluid, no Doppler changes, the diabetes should be well controlled with proper insulin dosage adjustments. And I would prefer to take the baby up to 37 weeks at least. And do not give a premature or even a late preterm would be, the baby will have some form of TTN. The baby might end up on a CPAP. So I wouldn't prefer delivering, even if it is uncontrolled diabetes. I would admit the patient, maybe for a week also, she might stay in the hospital. But with proper diet and insulin, I would control the diabetes, ma'am.
Okay. Sudesh sir, would you like to say something here?
Yeah, if it is a diabetes well controlled only with diet and exercise, now they recommended you go till 39 weeks. Then if it is controlled with medicines and injectables, they recommend to go till 38 weeks. But if it is uncontrolled, then you may terminate around 36 weeks or something like that. Because you have to control it. But if it is not being controlled even with medications and all, with insulin and all, then you may have to terminate little earlier.
Sucheta ma'am, the final word from you.
Yeah, I would like to highlight two things. One thing is pre-gestational diabetes, that is diabetes prior to pregnancy.
Yeah,
now
so that is what she has.
Now the
diabetes
HbA1
mellitus or chronic hypertension, anything, any maternal disease.
Let me come to diabetes, because the chance of stillbirth is more if pre-pregnancy HbA1c is high. Now, if pre-pregnancy HbA1c is normal, stillbirth is unlikely. What do we mean by uncontrolled diabetes? It's that 1 or 2 days fasting PP is not going to tell us whether the diabetes is controlled or not. It's the amount of liquor, that is polyhydramnios and LGA. That means probably this diabetes is not really well controlled. Then at that time,
of 12.5.
Sorry?
HbA1c of 12.5.
Pre-pregnancy.
Pre-pregnancy and even in pregnancy, because she refused to take a diet or any medicine.
Correct. So pre-pregnancy HbA1c 12.5 is severely uncontrolled diabetes. Then in pregnancy, if it remains to be uncontrolled, again, HbA1c is not a good indicator during pregnancy. So during pregnancy, to say that it is not good control, having good control, means there is polyhydramnios and LGA. Along with that, if there is new development of hypertension, that is because of maternal vascular disease secondary to diabetes. So if I consider all these things, I will not take pregnancy beyond 36 weeks. But at 36 weeks, I will admit this patient, give steroids, double the dose of insulin, if at all she is on insulin. And after 48 hours, maybe I'll induce or deliver this patient. Otherwise, there are high chances of stillbirth beyond 34 weeks. And you may lose a good size baby after 36 weeks. Now, if she's a GDM, gestational diabetes, then the case is not bad. But if she's not controlled, then delivery time is 37 weeks. But again, even at 37 weeks, in GDM and diabetic patient, we need to give steroid for lung maturity because there is delayed pulmonary maturity in babies in the mothers of who are having diabetes.
Thank you. Now we come to the last case. You suspect a large baby that, it's going at the 95th centile right from the 5th month onwards. When do you want to deliver this baby? Are you going to wait till 40 weeks, or means what are your triggers for delivering this mother?
Ma'am, if it's a complicated macrosomia because of comorbidities, then I will follow the rule of diabetes. I would control sugars, deliver between 38 to 39 weeks. If it is no other complications, only purely macrosomic child, because the mother is having she's a little of a higher BMI, both the couple is on the well-built couple, then I would wait till 40 weeks, ma'am.
Sucheta ma'am?
If it is diabetes and macrosomia, then follow principle of diabetes. If it is only macrosomia, that is baby is at 95th centile, I will not induce this patient. Still allow that patient to go in spontaneous labor. Because chances of shoulder dystocia ending up in C-section are more with induction of labor, with induced labors, rather than spontaneous labor. I think all of us must have delivered good sized babies. One of my staff nurse who delivered a baby of 4.6 kg vaginally. She was privy at that time. No diabetes, nothing. But spontaneous labor, it's very smooth. If you induce, do amniotomy and things like that, she's bound to go in dystocia.
Okay. But suppose she had GDM, then she has GDM.
If she has GDM and macrosomia,
39 weeks.
And then, yes, maybe, but diabetes is not controlled, then earlier, 38 weeks.
38.
Okay. So I think we are at the end of our session, and I want everyone, please give one take-home message before we actually end the session.
Actually, madam, I have a message for you. Once you get elected as a committee chairperson for this drug, please pursue that we should get alpha-DOPA, we should get freely available betamethasone, and third important is terbutaline. Because practically every alternate patient we use pitocin or oxytocin infusion for augmentation and induction, and we don't have terbutaline in hand. It's not at all freely available.
Okay.
So these three medicines should be available. That is our request to you.
For so many months, years actually, alpha-DOPA is stopped.
It is such a wonderful drug, and it was such a cheap drug. But unfortunately, it's not
available, but the availability is scarce.
No, it is not available.
Not available. It's not been available for years.
I think COFFY needs to take this matter with government authorities, and somehow we need to get this. If it is used in foreign countries, why not in India?
What happened?
The simple reason being is
alpha-DOPA is very cheap. There was one report when the Zika virus came up, and there were small-headed babies in UP and Bihar. That is when there was a report that said that methyl-DOPA, alpha-DOPA causes shrinkage of the fetal brain. And what happened? There was such a hullabaloo, and it was just blocked. You don't have it anymore. So we'll have to bring it back. We all have used it previously, but for years now it has not been available. Started with that Zika scare. Ma'am, I'll take note of all 3 points. God willing, I'll be able to do. Let us see.
Thank you.
Thank you, ma'am. Thank you for being here.
Thank you.
Take home messages from everyone, and we have 1 minute to end the session. Dr. Neeraj, we start with you.
Yes. Ma'am, thank you very much. It was a wonderful session. And I think the most important take-home message, what I at least learned is, be sure of the dates, proper sonological findings, proper Bishop score, then induce to give a healthy baby to the mother. Thank you very much, ma'am.
Thank you. Thank you. Dr. Sachin? ना सुदेश सर आप बोल दीजिए.
Yeah. We obstetricians need to believe that babies can be delivered vaginally with induction of labor. Belief is very important because that has been lost in the time because of lot of medical legal pressures and all things. No one wants to wait for 24 hours. The patients are so scary. So they will sit on your head. They will not let you eat. They will not let you sleep. But we need to make them believe, and we also should believe that induction of labor can end up in delivery of the baby and not always in cesarean section.
Thank you, sir. That's very important because our beliefs actually help us work. And what our belief is what the end point is going to be for sure. Dr. Sachin, you popped in. Want to say a few words? Sucheta, ma'am?
No, everything was wonderful. I think you have given lots of messages. Thank you so much.
Thank you. So thank you, respected Sucheta ma'am, Sudesh sir, Dr. Sachin, Dr. Neeraj, and all my viewers, Corona Remedies, the guest of honors, the chairpersons, the speakers, all for making this program effective. Thank you so much. Thank you, sir.